Hi there. This is Aaron Filler. I'm a neurosurgeon in Santa Monica, California, and this session covers peripheral treatments for central and autonomic disorders. The topics covered involve a number of situations in which there are autonomic ganglia that can be treated to resolve a number of types of pain and other dysfunctions that are helpful to have in mind in considering a patient's symptoms. When you understand the anatomy, the options for treatment include injections, and including, for instance, the use of hyaluronidase, which can relieve entrapments and help the distribution of medications. Also endoscopic neurectomies in some cases, and other decompressive surgeries to relieve adhesion entrapments that may be causing irritation or inflammation of ganglia so that a patient experiences an autonomic pain syndrome or an additional autonomic component to a general pain syndrome for an associated nerve nearby. The different areas we're going to run through are vagus and glossopharyngeal ganglion syndromes, the Eagle syndrome with superior cervical ganglion involvement, sphenopalatine ganglion syndromes, occipital neuralgia with autonomic components, and then for the abdomen, celiac ganglion, splanchnic plexus and celiac ganglia, superior hypogastric ganglion, and impar ganglion or inferior hypogastric. The first of these access issues I want to cover concern the proximal ganglia for the glossopharyngeal and vagus nerves. These give you access to treat a variety of types of afferent and efferent autonomic syndromes that affect a number of structures through the body, abdominal functions, the operation performance of other ganglia in the face, neck, and chest. And there is a common point of entrapment just below the skull base, and you'll find that physical exam manipulation raises the concern of an entrapment there. Neurography imaging can confirm adhesion and irritation of the proximal vagus and glossopharyngeal nerve just below the jugular bulb, and this is a location that's accessible for MRI-guided injections. What you're trying to accomplish with an injection like this is a block of the proximal vagus or proximal glossopharyngeal nerve, block of the ganglia between the jugular and carotid in the carotid sheath, and the purpose would be to diagnose a neurogenic cause for an abdominal disorder or other autonomic disorder, and perhaps obtain treatment when you include hyaluronidase. What you're seeing in the image on the right, the needle is pointed out, which is a MR-compatible needle that you can advance under MRI guidance very precisely in and among the vessels to reach the best location, and then in the course of injection, see that your anesthetic and your steroid and your scar-dissolving agents such as hyaluronidase are reaching the intended location. Now, another problem that arises adjacent to the skull concerns the pterygopalatine, or also called sphenopalatine ganglion. This is implicated in autonomic qualities for some types of headaches, with a focus in the temporalis muscle, temporal region, but also a variety of other face and throat autonomic functions associated with, for instance, the otic ganglion or other ganglia nearby. So with this anatomy in mind, there is a very nice access to reach this, to treat these areas of potential pathology. So what you're seeing here is an image from an MRI-guided procedure with the MR-compatible needle approaching from the right side. The needle is reaching deep into the pterygopalatine fossa, the apex of the fossa, and it is entering between the condylar process posteriorly and the coronoid process anteriorly. This is probably best done under anesthesia, so you can have the patient in a steady slack jaw position to get over the top of the mandible, and this gives you access to the sphenopalatine ganglia as well as other autonomic structures serving the throat and mouth. So from this approach, you can be doing injections with anesthetic, steroid, using hyaluronidase to relieve nerve entrapments. It's also a potential route for radiofrequency ablations and even for endoscopic treatments. Now, another interesting area of crossover between peripheral nerve elements and autonomic dysfunctions concerns what's called an Eagle syndrome, which involves a extended ossified styloid process which reaches to the hyoid complex. And patients with this syndrome will have the unusual pattern of severe ear pain with swallowing and may experience another set of a variety of posterior pharyngeal pains, and this also can gain an autonomic quality. Some of these patients develop a Horner's syndrome in association with the pain and with triggers to do with swallowing and speaking. You can diagnose a Horner's syndrome with MRI-guided injections. You can use hyaluronidase to try to relieve the adhesion, and there's always a possibility additionally for surgical treatment, which involves a partial resection of the excess ossified bony process with careful protection and mobilization of the associated nerve elements. Now, often enough, neurosurgeons are confronted with patients experiencing occipital headaches, which occur in association with head injuries, such as with a car accident. And what happens is that in a abrupt flexion of the neck, you can get small tears along the occipital nuchal line, and the greater and lesser occipital nerve branches, after they emerge from their C1, C2, C3 origin points, pass upward deep to the splenius and semispinalis muscles, and then perforate from the deep surface onto the superficial surface of the musculature, so that they can pass through the occipital nuchal line attachments for this neck musculature and reach onto the top of the skull and run anteriorly all the way to the forehead. Now, in addition to the fact that you can get occipital headaches, which may be very treatable by injection of hyaluronidase enzymes along the occipital nuchal line, but you can also get autonomic triggers along with this. I provide a citation to one article about trigeminal autonomic features in what is essentially otherwise seemingly an autonomic problem arising from an occipital nerve entrapment. And here, MRI guidance is helpful if you want to treat the selected compartments between the muscle layers in the upper posterior neck, but also to reach appropriate targets along the occipital nuchal line. Now, shifting our attention into the abdomen and chest, we have the splanchnic nerves arising from a series of thoracic levels, T5 to T12 and below, and these splanchnic nerves then feeding into the celiac ganglion, which will be located in a paraspinal location. these nerve elements can be involved in a variety of types of abdominal pain issues, and maybe worthwhile treatments can be directed at them if the appropriate access is achieved. What you're seeing here is an interesting approach, which is a transaortic fine needle injection to reach a celiac ganglion target. Now, you can reach this with a paraspinal approach, such as from the other side, and then use the hyaluronidase enzymes to allow the medication to reach the target if you don't have the direct access to reach the ganglion. This is also another area for potential endoscopic work on a transabdominal basis. Now, to provide a more extensive access to splanchnic and celiac components, it is interesting to note that some interventionalists do propose sending a small needle directly through the abdomen, passing through the liver and other structures, relying on the very small caliber of the needle to minimize harm, and in this way being able to reach any point along the splanchnic plexus, as well as providing good access to the celiac ganglion. Once again, the paraspinal approach may be sufficient, particularly if hyaluronidase is used to improve the distribution of the injected treatment agents. Also, of common concern for neurosurgeons is the superior hypogastric ganglion and superior hypogastric plexus. This is centered approximately the L5-S1 level, typically just below it, and this structure is the basis for the admonition many spine surgeons learn against using the Bovie coagulator, particularly along the inferior margin, the L5-S1 interspace, to avoid complex problems such as retrograde ejaculation and other pelvic congenital dysfunctions. The superior hypogastric plexus is also an important location to reach for a variety of neurogenic abdominal pains. And of course, there are many, many causes for abdominal pains, but in some cases, these will actually be neurogenic pains. So you may want to reach or block the ganglion to diagnose a neurogenic or nerve-originating pain, or to treat or block a pain arising in an abdominal structure where no other approach has been effective to resolve the pain. Particularly for cancer patients, sometimes an endoscopic neurectomy via approaches of this type is advised as a pain management method. And lastly, I want to take some time to discuss the impar ganglion, which is a name reflecting the solitary midline single aspect of this ganglion. And the location is at the sacrococcygeal joint on the inside, and usually directly between colon just deep to the ganglion and the sacrococcygeal joint just posterior. Now, this can be an important source of complex pelvic congenital dysfunction and pain, ejaculatory dysfunction, sexual dysfunction, hyperarousal syndromes, also urethral burning pain, incontinence, retention, and a sense of saddle area numbness. Now, this is important to keep in mind because when a neurosurgeon is presented with a patient having a complaint of incontinence and saddle area numbness, the immediate thought is to question whether this is a cauda equina syndrome needing urgent treatment, and imaging may show a routine disc bulge, but nothing that really would explain a cauda equina syndrome. This is a good situation to think of the impar ganglion. It's actually easy enough to test for. Most neurosurgeons are certainly familiar with palpating along the lumbar spinous processes. But if you continue downward and press on the coccyx at the sacrococcygeal joint and get a painful response, this is another reason to suspect this if there's a pelvic genital distribution autonomic dysfunction. Now, this can be tested and verified with a block of the impar ganglion. And in the past, these were considered very worrisome and difficult. In fact, one method that had been proposed is to make a small incision and drill a hole in the coccyx to get a direct approach from posteriorly. And really, I don't think this is generally necessary. I do these, and I recommend doing these with MRI guidance, although you can use fluoroscopic guidance or ultrasound guidance. And you come at an angle to the left and to the right to do the 2 injections. And again, with the hyaluronidase, you should be able to get good spread through the area of the inferior hypogastric plexus and across midline, although hyaluronidase may take several days or even up to 4 weeks to work fully. Certainly, if there's then a repeat injection, you'll have much better access. This type of approach is useful to keep in mind as you try to diagnose some of the puzzling autonomic syndromes that have a neurologic basis in the plexus. In summary, then, neurosurgeons should keep in mind that although we're often very comfortable diagnosing and treating cranial nerve syndromes and spinal nerve syndromes, and even some plexus syndromes to do with, for instance, brachial plexus, we're also able to diagnose and treat certain types of autonomic syndromes because these, again, are just entrapped nerves in many cases. And you can prove the diagnosis with these special set of injections directed at autonomic ganglia and often achieve treatment success with hyaluronidase treatments to relieve entrapments, RF ablations in some limited situations, and endoscopic neuroplasty or endoscopic neurectomy where these are indicated. Thanks.